Good morning, everyone here present at the breakfast course and the post-breakfast course. Thank you very much for being here so early in the morning and to listen to things called premium IOLs. But I'm sure that what you're going to take back from this course and what you have taken back already from the previous course is going to be so useful and so practical that you'll come back to the same course again year after year. I want to thank Dr. Purendra Basin for including me in this course, and Purendra, a good friend, a phenomenal surgeon, and he has got a phenomenal hospital as well. Let's start right. Let's start wrong. Toric markings, the first and the most essential. We wish to take you through the practical tips and the pearls. Therefore, I'm going to show you something that I did wrong. So, if a toric marking is wrong, your toric IOL will be wrong. And look at this. A little bit. See, I've marked the patient and I'm swabbing those portions to take the fluid out of the way. But what I am doing, the patient is moving slightly and my marker has moved out. And I am not mindful of the marker and I am marking my axis wrong. If you mark your axis wrong, your premium IOL will be wrong. So let's do it the right way. The ways of toric marking, they are simple, but they are very essential and they need to be accurate. So the slit lamp marking is one of the best markings. You seat the patient on the slit lamp, having him well oriented, and see to it that he is looking straight. Then, with the beam across his cornea, make it a thin beam, and with the orientation of the thin beam, mark. Also, you can do a marking in the patient's eye while the patient is in the theatre inside the OT, which is not really the best way to do. Best way, of course, would be marking in the slit lamp outside the OT. The innovation, I wish to show you an innovation in toric marking, and I wish you to think about other innovations because we have not come to the final and the best way to mark a toric. So this innovation is by Dr. Ayan Mahanto of Disha Eye Hospitals in Kolkata. Sound please. Sound please. Sound batao bhai. Audio visual sound dena hai.
This is basically an electronic camera leveling device.
1 minute, I'll just go back.
We are using this contraption for marking the axis before toric ICL for quite some time now. This is basically an electronic camera leveling device. It has a set of 5 LED lights with a green LED at the center, which glows when the device is perfectly horizontal. There are 2 LED lights on either side of the green one, which glows when the device is not leveled horizontally. The device has a foot plate which attaches itself to the horseshoe attachment in the body of toric marker. Now the device is ready for use. Now you can see when the toric marker is tilted, according to the degree of tilt, the red LED or the blue LED glows, and the green LED glows only when the device is perfectly horizontal and goes off when it is not. The toric marker is now inked and is ready for use. The patient's head is positioned on the slit lamp chin rest. The marker is slowly advanced towards the patient's eye and the patient is asked to look straight ahead. The marker touches the eye when the green LED light glows, thus providing accurate markings at the 0, 90 and 180 degree.
So that was Dr. Ayan Mahanto with his innovation in toric marking. Similar innovations, similar modifications can be seen by other users, and we definitely need to come to a category where we are able to mark a toric marking very accurately. Let's go on directly to the IOLs that provide the toricity. Now, Technis Toric IOL is a hydrophobic acrylic material IOL with a biconvex optic, and the beauty of this lens is haptics are offset and for a 3 point of contact and a fixation. It's frosted, continuous 360 degrees posterior square edge. These are benefits of the Technis IOL. The wavefront design, toricity and aspheric surface. These are all great things. 13.0 millimeters of diameter and 6 millimeters of optic diameter. That means your rexus should be good, accurate and very much central, and it should be as central and as perfect a circle as possible. The anterior cylinder axis marks the IOL meridian with the lowest power. So this is the Technis sheet that we get, and this is the toric calculation. After the toric calculation, they have a very good toric calculator which is very accurate. The Acris of toric design again is a single piece. We've known this lens for years and years. The benefit of this beautiful lens and the injecting system is phenomenal. It's open loop, modified L haptics, a posterior toricity and toric axis marks. Again, the dimensions are the same as the Technis, and the delivery is through either the B or the C or the D cartridge. So these are the indicator marks, and you can see the toricity on the posterior surface. And the extent of the cylinder that can be corrected from the 82 to 89 is 1 to 6 diopters in the IOL plane. The Rayner toric again is a very nice designed toric IOL, and it's a hydrophilic single piece acrylic with a posterior toricity again. The toric axis marks are there, and the dimensions again are the same, 13.6 millimeters, and it is slightly larger with a 0.5 millimeter larger optic and an overall diameter in the T-Flex 623T, and the power range is up to 11 diopters of cylinder. Now, I would like to show you the small video in which, where at times when the patient is moving a lot, it might be difficult to make a toric proper, accurate marking. And then what you can do is you can resort to something like this. You can identify the landmarks. You don't need to press on the globe to mark the toric. You can just identify the landmarks. And this is what I'm doing. I'm seeing that it is well centered, the marks are proper, and I've identified the landmark of a blood vessel in the actual position of the axis. And you can see the patient is moving a lot, and the moment I press it, it's moving. So I just identify the landmark blood vessel and then take off the marker and put in the mark, and then put in the axis markings. So the toric IOL can be used for these patients who have very high cylinders. This was one of our patients, Mr. Day, who had a very high cylinder, and it showed that there was a cylinder of nearly 7 diopters of, it was nearly about 6.25 diopters, the difference between the K1 and the K2. And then we opted for this calculation, went on to do Acrosoft IQ toric, and post-operatively next day, patient had 6.9 vision. And I would like to show you a very short clip before I end, and how to do a toric with a hydro insertion. You don't need to put in viscoelastic, because let us remember that all the viscoelastic above as well as under the toric IOL have to be removed well, because the centration and the fixation of the toric IOL in the bag is most important. So wish to show you that if you do it under hydro, then what can happen is like this. You have the irrigation port inside, and with the irrigation port inside, what you can do is very gently put in the toric, and with your aspiration, you can just put it in and swivel it inside the bag, and then put it in such a manner so that the optic and the haptics go in. Of course, there is a bit of stickiness there. You might have to require a little bit of manipulation to take the haptics, and then gradually you can shift it into the place. The benefit of this technique is, of course, that you do not have the visco under the between the posterior capsule and the IOL, and it can be well oriented. So these small little tips that I would like you to take back, and in fact inserting IOL under the hydro is a very, very good way Very simple, takes a little bit of practice, but can be done very, very easily by any expert surgeon. I would like you all to try it if you're not already doing it in your practice. The T-Flex, the aspheric Rayner, again is a very, very good lens, and this is the toric video of the Rayner toric, and with this lens again, the marking again is very important, and wish to show you a very cooperative patient, proper marking, and once the marking is done, then of course the routine is just about a routine. A good capsular axis, round and circular, should be central. What if the capsular axis runs out? That is one question. Doesn't really matter if it runs out, but if you do not have a posterior capsular tear, of course, or an extension into the posterior capsule, should you implant a toric IOL if there is a posterior capsular tear? The norm is you should not. Why? Because even after a very good vitrectomy, this toric IOL can shift. However, the merit of each case has to have its own demand, and if it is an IOL that is the posterior capsule has torn, and you can make it into a posterior capsular axis, you can fashion it into a posterior capsular axis, then of course you can go ahead and, judging yourself, you can put a toric in there. But of course, there has the vitreous, etc. management has to be very accurate, very good. And only if you think, yes, it merits, then only put it in. That is number one. Number two is, if there is an extension of the anterior capsular axis, what then? If there's an extension of the anterior capsular axis, again, there's a chance that the toricity will go or might shift. Again, it depends upon your personal preference whether you wish to put it in. Because if there is an axis shift, there is always a chance that the patient will lose the toricity. And these are little things that I wish to tell you, and things that you wish to take back home. Thank you very much. Thanks, Purendra, and thanks everybody for your patient hearing. Thank you.